I'm going to introduce Dr. Guerrero, and she's going to be talking about sleep health and chronic illness. Dr. Guerrero has been at numerous children's hospitals in Orlando since 2019. Prior to this, she worked at Montier Children's Hospital in Bronx, New York. Dr. Guerrero completed her pediatric residency and pulmonary medicine fellowship at New York University and Winthrop Hospital in Long Island, New York, and her sleep medicine fellowship at University of South Florida Affiliated Hospital in Tampa. Dr. Guerrero research interests are in sleep difficulties and movement disorders in pediatric patients.
Good afternoon, everybody. So today we're gonna speak about sleep and chronic pain. So my objectives of today will be talking why sleep is important. I'm gonna talk about what is normal so that you guys can understand what are the recommendations for sleep. So I'm gonna go through the normal sleep-wake regulation systems. I'm gonna talk about sleep hygiene, sleep health, sleep disorders that we see in children, and lastly, how sleep and chronic pain affect each other. So why do we sleep? It's essential for learning, memory, and cognition. It's important to keep a healthy immune, nervous, and endocrine system, and also to keep your vital organs healthy. And when we don't sleep a lot, it can interfere with our social daily activities, such as work, school, driving, trouble learning, focusing, and reacting. Sleep is important for every type of memory. The memories that it is important for is the memory for specific facts and events, for how we do things, and for long-term consolidation. It's important also for brain restoration and toxin clearance. It helps regulate a little bit of our immune cells too. It's also important to produce growth hormone that can be a healing process. It is important also for processing emotional memory. Dreaming is good so that we can dream and have that feeling that that something happened before, and then we feel like we can, if it happens in real life, we know what to do with it or deal with it because we have experienced that experience before by dreaming. So what happens when we don't sleep? So if we don't sleep, it can lead to physical and mental health problems, injuries, and loss of productivity. It can interfere with your work, school, driving, and social functioning. It can cause you trouble learning, focusing, and reacting. It's hard to judge other people's emotions and reaction. It can make you feel frustrated, cranky, and worried. And children may misbehave. They will have low school performances, and they may not have many attention to what's going on in their environment. And it prevents you from carrying out normal daily activities. It's also been linked to chronic health problems, including heart disease, kidney disease, high blood pressure, diabetes, stroke, obesity, and depression. So in general, what is normal sleep? It has a rhythmic and cyclic cycle. We have normally 4 stages of sleep, and we pass through each stage about roughly 90 to 120 minutes at night. The percentage of time we spend in each stage depend on your age. Like children spend more time in stage 3 because they produce growth hormone to grow. As we get in adults, we spend less time there. And the sleep needs, the amount of time patient needs is different also in infants, children, teens, and adults. So this is just a table showing the different stages, how it changes with your age. This is an important slide because when I come to my office, the first thing I ask, are you getting sufficient sleep? Are you getting the amount of time you need to sleep? So in a newborn, it's about 14 to 17 hours. In infants, it's about 12 to 15 hours. In toddlers, it's about 11, 14 hours. In preschooler, it's 10 to 13 hours. I'm gonna stop here because this amount of time until 5 years includes your napping time too. So between 1 or 3, we may nap twice, and between 3 to 5 years of age, we may nap once. After 5, we should not be napping anymore. And when you get into 6 to 12 years of age, you need to sleep about 9 to 11 hours, adolescents 8 to 10, and adults 7 to 9. So how is sleep regulated? There are 2 processes we have to take in mind. Process S, which is the sleep homostasis. Process C, which is the circadian rhythm. How fast and deeply you go to sleep depends on the difference between these 2 processes, and they have to work together to create a balanced sleep-wake cycle. So how do I explain the sleep homostasis? The way I explain it to my parents is the more time you're awake, the more time you're active, the more time you do exercise, it will increase a chemical in your body called adenosine, who will increase the need and the pressure to sleep and also may consolidate more your sleep. Now, this chemical is blocked by caffeine, so that's why one of the recommendations is not to have caffeine later in the day. We'll discuss that in a second. And it also will be blocked if you take a nap. If you take a nap, the chemical will go down and it'll take some time for the chemical to go up to increase that pressure again. Our circadian rhythm. Our circadian rhythm is our biological clock, and it goes into a 24-hour cycle. Why is this important? It's independent of sleep. The most normal trigger for our circadian rhythm is light, bright light. Once the bright light hits, it's the system that keeps us awake. And when light goes down, we produce our sleep hormone melatonin, and that's when we're gonna be ready to sleep. Other triggers for our circadian rhythm is regular meals, exercising, and social cues for work or school. So in this image, you can see the, I don't have a pointer, but you can see the process as the sleep onset will occur at an increasing sleep pressure due to the process S, and sleeping will happen when the circadian rhythm wakefulness drive will decrease. In this picture, you can see, for example, what I mentioned before. In the green line, you can see when a patient naps, and when you nap, the pressure will decrease. It will take longer for you to fall asleep, and it's not gonna be so consolidated sleep. And when you're sleep deprived, from the red line, you can see you will have a more consolidated deep sleep. This picture is just showing to you an average teen circadian rhythm. The reason why I put it here was because normally in our teenage year, our circadian rhythm changes a little bit. It may be due to puberty. Teenagers tend to sleep 1 to 2 hours later than normal. So sometimes they come into my clinic because they have difficulty sleeping and they cannot sleep within 1 to 2 hours, which can be a normal phenomenon for teenagers. So sleep hygiene. Sleep hygiene is healthy habits that can improve the ability to fall asleep and stay asleep. This is habits that will improve your overall sleep health. So this is for everybody. It's not only for children, it's also for adult, teens, everybody. And it's an important part of the primary treatment of insomnia in children, which is cognitive behavior therapy. So let's go through these, because I think this is important, because this can help your child sleep better. So what we need to start with is a consistent sleep schedule. Routine is important. It doesn't matter the age of your child, even smaller children, older children, they have to have a routine. In older children, it may be, in adolescents, may be a little bit difficult if they have a lot of social activity going on, but you want to try to keep your routine the same. You want to have a constant wake-up time. You want to wake up every day the same. So even weekends, vacation. I know during vacation, like summer now, a lot of kids sleep whenever they want, and they're sleeping 3 to 4 o'clock in the morning. So that moves your circadian rhythm, your biological clock forward, delaying it. So it's gonna be harder when school starts for them to try to sleep back at 10, 11 o'clock, when in the summer they were sleeping 3 to 4 a.m. So that's why it's important to try not to change your schedule too much from the school time to the summertime. Having a routine benefits children in providing them a sense of predictability and security. It helps them with activity transition. It moderates their impulsivity and self-regulation. It benefits also the well-being of family by decreasing child conflict. So normally, little kids or other kids don't want to go to sleep, so they will try to do everything possible to have later bedtimes. Sometimes these conflicts can happen also if your parents have like work that is later and they don't see their parents and they say they want to stay with their parents, so they want to get out of the normal routine. So with little children, I normally tell parents 1 to 2 hours before the regular bedtime that you choose to start their bedtime routine. And that can include taking a shower before, and that includes brushing teeth, putting pajama on. And then I tell them, give them some quiet playtime. Quiet playtime is a time where they can relax, not jumping, running, playing hide and seek and things like that, but just for them to relax doing something calmly that actually doesn't include electronics. So it wouldn't include any TV, phone, any tablet, anything like that. So those are the things that I recommend is playing with toys, Legos, drawing, knitting, reading, anything that you can think about that it doesn't include that. You want to have also an environment conducive to sleep. So you want to have a dark, cool, quiet place with no TV present. You want to teach them that bed is only for sleep, that the bed is not to play with it, the bed is not to do video games in it, the bed is not to read actually in it either. It's only to sleep. This is a way of training your brain that once my body gets into the bed, I'm going to sleep, and that's it. Okay? The other thing that we can recommend, though, if falling asleep within 30 minutes, it's normal. But if you don't fall asleep within 30 minutes, we recommend to get out of bed again and do a relaxing thing that I mentioned before. Again, like reading, drawing, you name it, and then you can go back to bed when you're sleepy and tired. You want to, and these are part of the relaxations that you want to do prior to bedtime. When you wake up in the morning, it's important to have a constant wake-up time. So you want to wake up every day, let's say an example, 8 a.m. In children that goes to high school, they have to wake maybe 5 a.m. and 6 a.m. in the morning. And at that time, there may not be light. But it's good that you eat or have breakfast 20, 30 minutes having light outside. Why? Because that will entrain your circadian rhythm biological clock to keep at bay and not to move around and change the hours of it. You want to have exercise during the day, but you don't want to exercise very close, as I mentioned before, bed, because that's really a relaxing time. You want to do it early in the morning or late in the afternoon. Now, as the lecture before, if you're in pain, you may not be exercising as much. However, again, you can do goal setting of how many exercise, and you can do a couple of exercises during the day than doing a whole like 30, 45 minutes of exercise. And eating regular healthy meals is also important. You want to eat a balanced diet in fats, carbs, and proteins, and vegetables and fruit. You don't want to eat a lot of processed food. You don't want to eat a lot of fried food or spicy food, and etc. Because that can cause you fatigue and tiredness depending what you're eating. As I mentioned before, you want to decrease stimulating activity before going to bed, and you want to have also not a lot of sugar or caffeine prior to bed. Actually, caffeine is recommended early in the morning, nothing after 12 p.m. if it's possible. And when we talk about caffeine, we're not talking only about coffee. Iced tea has caffeine in it. The energy drinks have caffeine in it. Chocolate has caffeine drink in it, so you guys have to limit those. You don't want to have a high carb meal at close to bedtime, because your metabolism should slow down in order for you to go to sleep. And if you give them a big food, then it wanted to digest it, and then you're working against your body to try to sleep. And as I mentioned before, no napping after 5 years of age. You want to stay awake. A lot of children after school, they're tired and they want to sleep around 4 or 5 o'clock in the afternoon. I tell most my kids at that time, it's the time you have to do certain type of exercise so that you don't fall asleep. And important, as I mentioned with the circadian rhythm, melatonin is produced when there's dim light. So if you are with electronics and TV, which has blue light in it at night, then it's gonna be harder for you to fall asleep, and you can make your bedtime later. So what is sleep health? Sleep health is a multidimensional pattern of sleep wakefulness adapted to the individual, social, and environmental demands, that promotes physical and mental being. This is not looking at what type of sleep disorders patients have and treating them. It's trying to look and focus on the individual and the population sleep rather than on the disorders. And it uses a social, ecological, and system framework. So here you can see what it entails, sleep health. So it has 6 domains. The domains are the behavior of the child, the satisfaction or quality of sleep, the alertness of being awake during the day, the timing of bedtime and the timing duration of sleep, the efficiency. Sleep efficiency is the time you're going to bed, the percentage of time that you're asleep compared to the percentage of time that you're awake. So for example, if you laying in bed for 10 hours, but in those 10 hours you only sleep 8 hours, then your sleep efficiency is 80%, 8 divided by 10. And the duration. So some of the individual child factors may be age that is interfering with sleep health, medical, neurodevelopmental health comorbidities, the temperament of the child. In the family and school factors, it may be the parent-child relationship. Parents can have some mental health or family stress that may affect the sleep of the child. The culture belief of the parents or the family also can affect it. If there's other individuals in the home, so for example, let's say a 7-year-old wants to sleep at the same time as his 16-year-old, which he needs more time of sleep compared to the adolescent in the house. And also some of the factors of the neighborhood. So if there's allergens, environmental allergens, if you're in a neighborhood that is full of violence, can affect it. It can also, if there's racism, all of that. School start it's a big thing, because in general, school starts later for younger children, and early for adolescents. And the adolescents normally have, as I mentioned before, the delayed 1 to 2 hours of sleep. So what happens, they can go to sleep at midnight and need to wake up at 6, so they have only 6 hours of sleep, and that causes them sleep deficiency. So these are the 6 dimensions that I mentioned. The satisfaction and quality really depends on the children's age and developmental level. They may not tell you, or unreliable report. Alertness during the wake-up hours. Some culture believes that napping is good. In Europe, people take siestas. If it doesn't cause you an issue in sleeping at night, it's okay, but we recommend if you nap to keep it below 30 minutes. Timing of the sleep, again, will depend on your parents' work hours. Some kids, because parents work during the day, want to spend time with their children during the night, and etc. And the sleep duration we have an average that I gave you before of the time that patients need to sleep, but kids with neurodevelopmental delay like autism, cerebral palsy, or anything like that, we don't know how long really they need to sleep. And the behaviors is a big thing in children. What are you doing before to sleep? As I mentioned before, if you're on electronics for a long time, prior to your bedtime, it may affect and make you later bedtimes. So what sleep disorders do we have? We normally have 6 sleep disorders. The main one is insomnia. Insomnia is difficulty going to sleep, difficulty maintaining a sleep, and having different awakenings during the day that will affect your daily activities in your daily life. The other one is sleep disordered breathing. This is our obstructive sleep apneas. This is our central sleep apnea. This is low oxygen, and etc. If you're not sleeping, then you're sleeping too much. That's hypersomnolence of central origin. These are what we see with narcoleptic kids, that they are sleeping all the time, all the time, all the time. They're sleeping 16, 20 hours a day. Other sleep disorder are movement disorders, that is restless leg syndrome. Restless leg syndrome is a clinical criteria, and basically this can cause also insomnia, because the criteria is that you have weird feelings in your legs at night, that it doesn't improve, that improves with movement and massage, it makes you difficult to fall asleep. Normally in children, this can be because the iron stores are low, and we supplement with iron during this time. And we see it a lot in young children when they become picky eaters. They don't want to eat iron-rich food. Kids don't like liver and etc., so they don't eat that. Circadian sleep disorders are the disorders of your biological clock. As I mentioned, teenagers can delay and make it a later time to fall asleep. As adults can make it earlier. It's called an advanced sleep phase. Parasomnias are the last sleep disorders that we see, and those are the sleep terrors, the nightmares, and the sleepwalking. So in rheumatological disorders, the most common sleep disorders that we see is basically insomnia. It's decreased sleep, it's sleep disruption, it's a lot of awakenings during night. But in certain of them have other sleep disorders also. You can have more than one sleep disorder. So in juvenile idiopathic arthritis, you may see obstructive sleep apnea and parasomnias. So one of the new recommendations are that when you see your rheumatology or any doctors that you're seeing for your GIA, that they ask you about questions about obstructive sleep apnea, because obstructive sleep apnea can make your fatigue also more worse. Even though some of the medication of GIA can make you fatigue or tired, if you have OSA on top of that, it can make it worse and you would want to treat it. Sjogren's syndrome, you can see periodic limb movements or restless leg, systemic lupus erythematosus, you'll see OSA, restless leg, periodic limb movement, narcolepsy or cataplexy. Scleroderma, you can see restless leg and periodic limb movements. Ankylosing spondylitis, you can see obstructive sleep apnea and you have fatigue pain. Fibromyalgia, you can have excessive daytime sleepiness, fatigue, pain, depression, insomnia. And you can have also obstructive sleep apnea, restless leg, and periodic limb movements. So what is the relationship between sleep and pain? So chronic pain is pain more than 3 months. So patients with rheumatological disorders, fibromyalgia, and musculoskeletal pain can cause disturbed sleep and daytime fatigue. And 50% of adolescents with chronic pain have insomnia symptoms. What does sleep do to pain? So sleep, if you're not sleeping much, you can have episodic acute pain. You can have increased risk of new incidents of chronic pain in pain-free individuals. You can have long-term worsening of long-term prognosis of existing headaches and chronic musculoskeletal pain. You can have daily fluctuations in your clinical pain. So it's very important to sleep. And we know that poor sleep also has negative impact on health-related quality of life. Adolescents with poor sleep efficiency, and difficulty initiating and maintaining sleep have more limited daytime activity than adolescents with pain that have no poor sleep. And it also restricts your academic activities. So it used to believe that pain and sleep has a bidirectional relationship, but as more studies are coming out, it seems that sleep has more effect on the pain than pain has on the sleep itself. So it's very important to treat sleep disorders and improving the sleep by keeping a good sleep hygiene. And I will discuss in a second what is the treatment for sleep if you have difficulty sleeping. So how do we assess sleep? History is very important. When patients come to my office, I ask everything. I tell my adolescents, don't feel weird about it because I'm gonna ask you questions that you don't imagine that I'm gonna ask you. But I ask what they do in the daily activity. I ask them what do they like to eat. I ask them how they're feeling, how they're doing in school, what they're doing in school, and etc. There are a lot of questionnaires that you can do for assessing some of the sleep disorder. A pediatric sleep questionnaire can assess about obstructive sleep apnea, so it can be used in clinic of other providers. I use a lot sleep diaries because sleep diaries can give me information, or sleep logs can give me information about the time you're sleeping. It tells me what time are you falling asleep, what time are you waking up, because that can give me information that if you have a circadian rhythm disorder. I also ask always about all my sleep disorders that I mentioned before. So all the 6 sleep disorders, I ask all the questions about that. Objectively, how do we assess sleep? We normally do a sleep study in patients that were suspecting sleep disorder breathing, like obstructive sleep apnea. The sleep study also can give me an idea how your sleep architecture is, if you're passing through all your 4 stages of sleep, if you're cycling through them. It can give me also information if you're moving a lot that may be suggestive of restless leg. But it's not gonna give me information that you're not sleeping and you have insomnia. So that's why I use sleep logs. It also doesn't tell me if you have a circadian rhythm disorder. That's why I use a sleep log, because those are the ones. And if you have difficulty sleeping, I tend not to send patients to the sleep lab until they're sleeping better, because we need at least 6 hours of sleep for a sleep study. So if you're sleeping 3 to 4 hours, that's not enough information for me, so I work on improving their sleep in order for them to go. Another thing that can be used, but it's used more for research and clinically, some places have it and some places don't, is actigraphy. Actigraphy is like a watch, a wrist watch that you put on your non-dominant hand, and it moves, it goes on movement. So the more you move, it tells you like you're awake. The less you move, it implies that you're sleeping. So it's an indirect way of seeing if you're sleeping or not. So the lecture before me talked about mood disorders, about depression, and yes, depression can cause you to have anxiety. Depression and anxiety can cause you to have difficulty sleeping. It can cause you to have insomnia. So sometimes I have to ask patients about these disorders also, because I'm not a psychologist to help you on the depression and anxiety part. I can help you with your sleep, but it's gonna be hard for me to work if you have anxiety towards sleep or if you have depression. So we have to work together in order to help the patient in a total way. And as I mentioned before, mood disorders, depression can is associated with increased pain. You have also anxiety that will give you negative thoughts, negative emotions, and that can cause more difficulty sleeping too. And insomnia and pain also is associated with increased pain intensity, sensory pain rating, affective pain rating, general anxiety, general depression, and health anxiety. So this is a table showing what sleep deprivation does. So in a sensory component, it increases pain sensitivity, it increases the temporal summation of pain, it decreases pain threshold, and it impairs conditioned pain modulation. In a physiological component, it increases depression, anxiety, stress, and decreases positive effect. In a social component, it increases isolation, loneliness, restriction in daily activity, and decrease in social interaction. So here we go. How do we manage this? So the first treatment for treating insomnia or difficulty sleeping is cognitive behavioral therapy of insomnia. It's psychotherapy. These are mostly done by psychologists, and as mentioned before, yes, there can be a shortage of them, but if you have counselors can be taught in this, you can use your counselors too. It's more effective than drugs. So it's the first primary treatment recommended by the American Academy of Sleep Medicine. And insomnia, chronic insomnia is considered if you have sleeping difficulty more than 3 months. The main components of cognitive behavior therapy is stimulus control. This is what I was mentioning before, teaching your body that when you lay in bed, it's to sleep and not to do anything else. So it's the recommendation I gave before that your bed is only for sleep. If you don't fall asleep within 30 minutes, get out of your bed, do something relaxing. You may want to buy a bulb in the room if you have to turn a light that doesn't have blue light so that your eyes are not stimulated much. And this is sleep stimulus. Sleep restriction is when, for example, if I have an adolescent that is spending 12 hours in bed, sleep restriction is saying, well, an adolescent needs to sleep 9 to 10 hours. I'm gonna put him in bed for 9 hours only to make sure the time that he's in bed, he is sleeping and not waking up. A lot of people think that, oh, I didn't sleep a good night, let me spend more time in my bed to fall asleep, but it's actually the opposite. You want to be in your bed the only time that you will be sleeping. And it actually, sleep restriction is the a treatment for sleep maintenance insomnia. So when patients don't have difficulty going to sleep, but they wake up multiple times at night, and normally waking up 1 to 2 times at night is normal as long as you go back to sleep within half an hour. So for example, with sleep restriction is that if the patient is 8 hours in bed, and from this 8 hours, they're sleeping only 6 hours, what we recommend you be in bed only for 7 hours, not to be the whole 8 hours in bed, so that we can consolidate your sleep and making sure the time you're in bed is sleeping and not waking up. And once patients are, so sometimes I have to do the patients a little bit, give them a little bit of sleep deficiency before for them to have a consolidated sleep. But then what I do is I tell them you can move your bedtime backwards every 15 minutes every 3 to 4 days. So if you're sleeping from 9 to 6 and you're sleeping good, not waking up, no issues, but you're not at the amount of time you need and you still feel like tired during the day, I tell them, well, move your bedtime 15 minutes every 3 to 4 days. So that would be 8:45 to 6. If you're still falling asleep within half an hour, if you're not waking anymore up during the night, then you can go to 8:30 and so on forth. That is how I use sleep restriction. And one other part is the relaxation buffer worry time. So that's what I was saying before with sleep hygiene, that 2 hours before your bedtime, you want to really have your relaxing time. If you're anxious because you're not sleeping or anything like that, what you can do are muscle relaxation techniques. You can meditate, you can do breathing exercises. All of these you can actually find on YouTube, but I tell my patients, learn how to do it before you go to sleep. Don't do it when you're going to sleep because that is light therapy and that's looking at blue light. So I tell them to learn that before going to sleep. Sleep hygiene, we discuss everything about sleep hygiene. Cognitive reconstructing is just making negative thoughts positive, making sure that sleep is a positive thing. Sometimes little children, I have to tell parents to do calendars and put stickers on the calendars and reinforce the child that sleeping is good. So if the child can count, and depending how far they can count, I tell them after 3 stickers, after 5 stickers, you can give them a prize. Kids work on positive reinforcement. And the prize doesn't have to be monetary. It can be going to the park. It can be going to the pool. It can be what else can it be? It can be 20 more minutes in my tablet or watching my favorite movie early in the day, not close to the bedtime. Because sometimes the recommendation says that you have screen time about 2 to 3 hours a day, so you don't want to pass that amount either. We're living in a generation that everybody, even us, are on the phone. We live on our phone. We live on looking what is happening in the media, so it's hard. We spend a lot of time in front of a screen, and we need to just appreciate what's going on around us. And lastly is the circadian rhythm entrainment. That is basically making sure that you have your light in the morning, making sure you're having your 3 meals a day, making sure you can have snacks in between, making sure you're doing exercise, making sure that you keep your biological clock checked, because if you're moving your things around, your biological clock also may move, and then you're gonna start having circadian rhythm disorder. Children with GIA treated with cognitive behavior therapy showed significant improvement in sleep quality, pain control, and physical functioning compared to control groups. So this is where cognitive behavior takes place. So with insomnia, you may have worrying thoughts, you're ruminating, racing mind. So sometimes for cognitive behavior therapy, I tell my patients, you can write in a journal, write everything down. When you write everything down, it goes out of your brain into a paper that you don't have to think about it anymore. So it tends to relax them. And especially if it gives the patient anxiety. It affects the negative behaviors. You want to have a positive behavior and not for them not to be scared for sleep. Sometimes patients are anxious that they're not sleeping, and you want to tell them, okay, and sometimes sleep logs help with that, because in their mind, they may not have slept in a week, 2 days, but then if you see for the last 5 days, they slept good, but in their mind, they just remember the one that they didn't sleep well. So it's good to have a log so that they can see, oh, yes, you're right, it's not that bad, or it is improving. Like I have a lot of patients coming in, nothing has helped, but they show me the sleep log, and I had sleep logs before, and you see improvement, and I show them, they're like, oh, okay, you're right, something is improving. So again, it kind of show them what is going on. There is also cognitive behavioral therapy for pain. Again, psychology would be the person to teach you this. These are all the therapies that they use: acceptance and commitment, mindfulness, motivational interviewing. And it's also all these therapies is trying to change your thought, trying to change why you're doing certain behaviors. For example, the motivational interviewing is opening questions to try to see why you're doing a behavior and then try to fix that behavior. It also can help parents. As the psychologist says before, you can have goals for certain things, with the parent, using parents, parents can be like co-therapists or co-helpers, but sometimes parents also are stressed with the situation, and sometimes they have to do treatment for both the child and the parent. And again, these therapies reviews have shown that it reduces pain intensity and frequency, so they're good. And their aim actually to control pain and modify the situational, emotional, familial, and behavior part of the pain. I don't know if you can see this very well, but these are an example of mindfulness exercises, so that we can try one when we finish the talk. The people that are here, if you're interested, we can do a exercise of muscle relaxation later, so that you see how it feels. But these are example. The names are the body scan, the breathe and smile, sober breathing space, a walking meditation. All of these, if you put in YouTube, you can see it. They tell you how to go through it. It can be helpful. So this is the progressive muscle relaxation. At the end of the lecture, we can do it and see how you guys feel about it. So they have talked about amplified musculoskeletal pain. The reason why I put this slide here is because any of the diseases, the GIA or the EMS, everything, you want to treat the underlying condition first, especially because it's a condition that causes pain. It causes pain it gives you arthritis. So you want to treat the underlying cause first. So amplified muscular pain syndrome, it's an array of pain syndromes, including complex regional pain syndrome, fibromyalgia, and diffuse and localized muscle pain. Treatment is a multimodal approach. You want to limit painful symptoms and optimize function. You want to have physical therapy, occupational therapy, and they can do massage, from massage to contrast bath in it. Medications for pain can be given. Again, pain physiology, I think it's very important, like biofeedbacks, cognitive behavior therapy. You want to have adequate sleep and hydration. With juvenile idiopathic arthritis, the rheumatological guidelines from 2021 are these. You start with non-steroidal anti-inflammatory agents. You can do intra-articular glucocorticosteroids. You can start disease-modifying anti-rheumatic drugs. You can do also the biological disease-modifying anti-rheumatic drugs. If you have systemic, you can go into include interleukin-1 and interleukin-6 inhibitor monotherapy. So this is the question that a lot of patients come to me and ask me, my patient is not sleeping, I want to give them something to, and you need to help me. I want to give them some medication. In general, there's no FDA-approved medications for insomnia. I tell parents that the treatment is the cognitive behavior therapy. The problem is that it's convincing everybody that this will help, because this won't help if the patient won't do it. My teenagers, every time I go through everything as I went through with you guys, they're like, I don't think I can do this. No, I'm not gonna do this. So if they're not doing it, it's very hard for it to work. And then I tell them, okay, don't expect you have a change tomorrow. It will take a time for your body to accustom and get into the rhythm. It'll take time. Even with smaller children, I tell the parents, sometimes I can make your life miserable at the beginning, but at the end, you'll see the good coming from everything you're doing. And consistency is very important. There are medications we use clinically to help you going to sleep, but even if I use those medications, I tell the parents you still have to do the cognitive behavioral part of it. It's not just a medication and that's it. Again, medication may help 2 to 3 months or less, and then it doesn't work. You have to do the behavioral part too. There's not much control studies in children. They have done control studies like in melatonin in children with neurodevelopmental delay, so that's like the autistic, the cerebral palsy, and they have shown that melatonin in these population, they shown the safety and efficacy, and they've shown that it decreases your sleep onset or sleep time to sleep about 30 minutes if you use melatonin. However, melatonin is not FDA regulated. You buy it over the counter. So a lot of people, when they come to my office, already have been on melatonin. They're like, it doesn't work. Again, I tell them, okay, let's see what's going on. What are you doing? What are you doing that is malconductive? What are you doing that is affecting your sleep? And then let's work on that, and then we'll see. And melatonin can be used for 2 things that I tell always the parents. Melatonin can have sedative effects, make you sleepy in the higher doses, but melatonin is also used as treatment for my circadian rhythm disorders. So you do low dose of melatonin for those cases, and you do it early to regularize the production of melatonin. So in summary, it takes a village to treat these patients. For patients with rheumatological disorder and sleep issues, it takes a rheumatologist to treat the underlying condition, psychology to do the cognitive behavior therapy, psychiatry maybe for anxiety and depression. You may need, if you don't have a psychologist, you may have a counselor, social worker that can help you. You may use a sleep doctor to help you sleep better. and also to rule out these sleep disorders that need to be treated. You may need, if your pain is really bad, you may need a pain management specialist, and you need physical rehabilitation. There are online cognitive behavior therapy for insomnia courses, but they're very expensive. There are apps on the App Store that you can use some of the cognitive behavior therapy. There is like the iAct app. I just opened it a couple of days ago, and it gives you the basic, but if you want to have more deep treatment, then you have to pay more money for it. But it's like you can download it for safe, and there is some meditation, some relaxing techniques and relaxations and everything in those. They asked me to say how we can find a sleep medicine doctor. Normally, I say Google any sleep medicine doctor board certified around your area. If there's a center, if there's a sleep lab, you can call your insurance company and go from there, or referral from your main doctor. Questions? Yes.
What would you consider a low dose of melatonin and a stronger dose of melatonin? Like what
So
membrane?
5 to 10 milligrams is more for helping you fall asleep, but it depends on the age of the patient, right? The younger children may need less melatonin than the older children. So in children that are school age, I start at 3 to 5 milligrams, and then I do older children 5 to 10. Low dose melatonin is from 0.5 milligrams to 1 milligram, like very low dose.
Thank you.
You're welcome. And by the way, with melatonin, I always recommend to look at the back of the bottle. Why? Because sometimes the bottle says sleep easy, sleeping good, or anything like that. And then you turn the bottle, there are many ingredients in there that are not regulated. So I always say, look where it says only melatonin, not that there's GABA in there, not that there's valerian root in there, not that there's anything in there, only melatonin. Go ahead. No, good, no problem.
So you mentioned a pattern for pushing like sleep start time back.
Yes.
So I'm also a therapist, so asking as a
Awesome.
mom and a therapist.
Awesome.
Where we are in North Carolina, we actually have where the adolescents start school later.
Oh, cool.
I know, it's
That's amazing.
fantastic. I was
That's-
shocked.
Yes.
But what we run into is that we have to have bedtimes when it's still sunlight outside.
So,
Often asked, how do I move that bedtime back to get that correct number of sleep hours when the sun isn't quite set yet?
okay. So let's go backwards. So normally when I have a patient like that, I ask them so I always start with wake up time. What is the latest you can wake up during the day that and that you can do everything that you do in the morning? So for example, give me an example what time your son has or daughter has to wake up.
So my high schoolers get up about 6:30.
6:30, okay. So the high schooler needs about 8 to 10 hours of sleep, right? So if the wake up is 6:30, then the nighttime, if I always take the average, let's do 9, would be 9:30 p.m. By 9:30 p.m., you have the sun out?
As in the late summer, yeah, it's still sunset around like 8:45, 9-ish sometimes. Like,
So then what I would recommend 2 hours before your bedtime, so let's say we want to sleep them at 9:30, at 7, not to be outside, be inside in the house, do some relaxing things, and you may want to be in a room that doesn't have a lot of light. So that is the room that I would say you can buy just one bulb, not all your house, but you can buy a bulb that doesn't have blue light and keep that bulb on so that they can do things in like dim light so that your regular melatonin can be produced.
and if someone was trying to move that bedtime back,
So if you want to move the bedtime, right, it's the treatment of circadian rhythm. So the treatment of circadian rhythm is bright light therapy when you wake up in the morning, and you give melatonin 5 to 6 hours, low dose, before your regular bedtime. So that would be 5 hours before the 9:30, which would be 4:30 p.m. So it sounds very early, but that's kind of what it is to try to move it backwards.
Thank you.
No problem. And the light, don't forget the light. You can get light boxes of 10,000 lux too, so you don't need necessarily to be outside if your child doesn't want to be outside in the heat. There are light boxes that are 10,000 lux that they can just look through it. Actually, it helps also with patients that are stressed and anxious, that it relaxes them, or depressed. Any other questions? Anybody online?
No comments or questions at this time.
Okay, do you guys want to do then the relaxation techniques? Are you guys ready? I think I'm the last one today.
Yep.
Okay, so let's start being comfortable in your chair. Okay, now I want you guys to close your, my voice is not that calming as the meditation, I'm so sorry, but I'm not that calming, but let's see. Close your eyes. Breathe in and breathe out. Put attention to your breathing. Make sure you're breathing in and breathing out. Now I want you to breathe in and hold it. And breathe out. Let's repeat that. Breathe in and breathe out. Now I would like for you to breathe in and breathe out again. Feel your breathing. Now I want you to tense your forehead by increasing your eyebrows. Bring your eyebrows, keep it, feel your muscle tensed. Bring it down, relax. Feel how your forehead is relaxed. Now I want you to squint your eyes and move your nose towards your eyes. Feel the tension. Keep breathing in and keep breathing out and feel the tension. Now relax. Now I want you to breathe in and breathe out again. I want you to breathe in and hold again. Breathe out. Now I want you to smile and clench your teeth in the front. Feel the tension of your jaw. I want you to relax now. I want you now to shrug your shoulders towards the ears. Feel the tension. Keep on breathing in, keep on breathing out. Relax. Breathe in and breathe out. Be familiar with what you're feeling in your body right now. Keep on breathing in, keep on breathing out. Now I want you to clench your hands, make a fist, strong, and go towards your shoulders. Bring it up to your shoulders. Yes, thank you. And then breathe in, breathe out. Keep it there for a second. Feel the tension. Now relax, open your arm, put it around your legs and your, exactly, there. Breathe in, breathe out. Breathe in again and hold your breath. And breathe out. Now I want you to think about arching your back and like your shoulder blades coming to each other. Feel the tension. Breathe in and breathe out. Release it, let it go. Again, keep on breathing in, keep on breathing out. Breathe in and breathe out. Now I want your belly button to go all the way to your spine. Breathe in and breathe out. Feel the tension in your abdominal muscles. And relax. Breathe in and breathe out. Now breathe in and hold your breath again. Breathe out. Now we're gonna push with our heels to the floor as much as we can to tense our hamstring. Your buttocks also press them together. Breathe in, breathe out. Now relax. Breathe in, hold your breath, and breathe out. You can open your eyes. How do you guys feel? Thumbs up if yes, thumbs down if not helping. Okay, thank you very much, guys. If you have any questions, I'll be around here, okay?